So I'm very excited to be here. The most exciting thing about my talk is this. I've never, ever actually given a lecture where I was the one controlling this, so it may not work. And I also want to warn people who have attended a lecture I gave at the Cross last year on medulloblastoma. There's some slides from that, so there may be a sense of deja vu. All right, so I have a lot of slides, but many of it is fairly conceptual and quick. But the title of my talk is whimsical. It's battling cancer one child at a time. And the reason I use this title, which I'm sure others have used before me, is that we've built our success in pediatric oncology through clinical trials, enrolling one child at a time, and made, I'd say in my lifetime, tremendous progress through this mechanism. And I'm just going to segue, because I'm at a particular age where I can look back actually more than 40 years and think about when I was in grade 1. And I tell this story because it's true. A classmate of mine named Michael didn't come back to school one day. I found out later he had childhood leukemia. If he were diagnosed today, he would have close to a 90% chance for cure if he were standard risk. So in my lifetime, tremendous progress. So I'm going to talk today, give an overview of childhood cancer with an emphasis on brain tumors. And many of these slides have been borrowed and modified from Paul Grundy. I'm going to talk about how we've made progress one child at a time, and I'm going to focus on what I know, which is pediatric brain tumors, in particular medulloblastoma. I'm going to talk a little bit about cancer genetics. I'm going to talk about why follow-up is so important, and then I'm going to briefly introduce the topic of why teenagers are a pain. So, without further ado, here's your first question. And what is the leading cause of death during childhood? Cancer, congenital heart disease, accidents, poisonings, or homework? All right, I don't have that many jokes. But all right, so click away. And I'm not sure how much time I'm supposed to give you, but I'll give you a few more seconds. In my household, the answer is E. All right, so now I'm going to stop the polling, and here's our display. And the answer is accidents. All right, and that is correct. So yes, accidents are the leading cause of death in children under the age of 15, but cancer is right up there. So cancer is the leading cause of death in children after accidents and trauma, and after leukemia, brain tumors as a group, and there are many different types of tumor, the most frequent diagnosis, the most common solid tumor. And the most common malignant brain tumor of childhood is medulloblastoma, but it's not the most common brain tumor. It seems to me that most of the Royal College exams in pediatrics that focus on oncology just ask that sort of question, so I thought I'd just put it right in there. So, but when you look at the incidence, it's actually not very high, 150 cases per year per million children, and the incidence of childhood cancers remained rather static over time, and given on that the Canadian population is larger, maybe in a busy year we might have 1,500 cases. If you look across the age spectrum, though, we see some peaks. And one peak is between the ages of 2 and 4 years. And we see many of our children with leukemia, some types of brain tumors, Wilms tumors, what have you, in the younger children. And then there's a fall off. And then as we get into the teenage years, it picks up again, with different sorts of cancers. And this just sort of shows you how that works, where the younger patients will have tumors that many of you are familiar with, the neuroblastoma, Wilms tumor, etc. And then as we get into the early childhood years, we see the low-grade gliomas and leukemias, and then in the teenagers, the various sarcomas, Hodgkin's disease, etc. Now, if you look at overall cancers, the most common things, and if you're a bean counter at the provincial level, you're going to focus on the most common types of cancers that we see in the population, not in children. Prostate, breast, lung, and colon are the so-called big four. But if you look at childhood cancers, they're kind of once you get past the big four, they do have a major impact when compared to some other cancers that we hear about. Now, one of the controversies, and this has to do with various populations, is where do you cut off childhood? And this comes up in children's hospitals. I'm not going to go into that, but some of the statistics, if you go online, will call it under 15 or under 21 or under 20. So I think one has to be wary of where the cutoff is. So the incidence is about 1 in 7,000 children per year, but it's 1 in 500 children during their childhood. Whereas if you look at the incidence of cancer overall as one ages, we all know people who have cancer as we get older. So the incidence increases over time, but the types of childhood cancers we see really don't occur. Except one that I think is worth mentioning, the medulloblastoma, about 25% occur in adulthood. So if you're from the perspective of the physician in the community, if one finishes family medicine and you set a practice before the age of 30, you might see a couple of kids with cancer in your entire career. The average pediatrician who's busy here in Edmonton might see 1 or 2 per year in their practice. So it is worthwhile to be aware of these diagnoses. So even though pediatric cancer is rare, we've really rallied the troops to deal with this. And just like many other subspecialties in pediatrics, it's a multidisciplinary approach. And the team is rather large. I don't have to read this entire slide to tell you that the oncologists or hematologists are just part of the story. We have many other physician practitioners who contribute, and then we have nurses, psychologists, social workers. So it does take a village, and it's this whole team approach that, in my view, has led to increased not only survival, but reduced morbidity and mortality. Part of what we've accomplished has been through cooperative group trials. And about 15 years ago, there were 4 different groups operating in North America. There was the National Wilms Tumor Study Group, there was the Rhabdomyosarcoma Sarcoma Consortium, there was the Pediatric Oncology Group, or POG, and Children's Cancer Group. And the National Institutes of Health, NCI, essentially told the groups that they had to work together because of the rarity of the disease and to make progress a little faster instead of having competing studies where you wouldn't necessarily have enough patients to move forward. It was very political, but I can tell you now that after 15 years have elapsed, this has worked for the most part, although I'd say fiscal constraints, especially in the U.S. government, have led to having fewer clinical trials. So some of the rare things that we see are not being studied the way we used to study them 10 years ago. So what are the causes of cancer in childhood? The environment is actually not making a significant contribution, at least that we see during the childhood years. And maybe childhood exposures do place us at risk in older life. And that's why, in part, my predecessor, Paul Grundy, brought environmental health into the group, because prevention is important. But prevention doesn't necessarily have an impact in the childhood years. There are a number of predisposing syndromes. And there's certainly adult cancer predisposing syndromes that can have cancer as a phenotype. And I have a multiple choice question in a second. In childhood cancer, the predisposition syndromes are often part of a recognized syndrome, however. So here's a question. Of the following syndromes, which one is not typically associated with childhood cancers? Beckwith-Wiedemann syndrome, neurofibromatosis type 1, Down syndrome, Leigh-Ferrandini syndrome, and Lynch syndrome. So click away. This question's a little harder than the one I had before. I'll be checking members of my division to see if they got the question right. All right, some of you are answering. I'll give a few more seconds. All right. So I knew that D&E would cause trouble. Leigh-Ferrandini syndrome is with germline p53 mutations, and this is not a molecular biology talk, so I'm not going to go into detail. But childhood cancers are associated. One that is near and dear to my heart is choroid plexus carcinoma, but that's pretty rare. Lynch syndrome is a type of colorectal cancer that we see in adults, and it's to do with DNA repair enzymes. So Lynch syndrome is the one that is wrong. So that was a hard question. All right. Let's see if I can get this going again. All right. So how do children present with cancer? The answer is in any possible way. And the punchline for the residents here is listen to the parents. If mom is worried, listen, because sometimes moms are right, especially my mother. So what are the typical symptoms? Many of them can be pretty nonspecific. Weight loss is certainly a concern, or failure to gain weight during childhood. But if you look at all of these, even limp, vomiting, headache, and large lymph nodes, none of them really are a smoking gun per se. There are some typical symptoms. Obviously, a child presents with a new mass. You should pay attention to that. But sometimes it can be subtle. For example, if you see a varicocele in a child under the age of 6 months, maybe you should think about a retroperitoneal mass. You'd be amazed how many people don't. Unexplained bruises or petechiae, but small children get bruises, especially from the knees on down, and neurological signs that can't be explained. So although symptoms are common, cancer is not. This is one of my favorite slides of Paul's. Symptoms are not usually due to cancer, and usually the diagnosis is not apparent, especially at the first visit. So here's the next question, and I think you'll like this one better. What is the overall cure rate for children diagnosed with cancer? 20, 30, 50, 70, or 90%? You guys are answering faster. All right, and answer D is correct. We would love to see E as our answer, and for some pediatric cancers, we do see that. So about 70% overall. So to our medical oncology colleagues, well, we've got you covered. So there are some very high rates of cure that we see. And actually, the word cure is a bit problematic to me. And early on in my career, I was very enthusiastic about using that word because I thought I knew what it meant. Now that I've been in practice 20 years, I'm not so sure. To me, cure is just a short word for long-term remission. And if you stick to the end of the talk, you'll see why. But Wilms tumor and Hodgkin's disease, not all types can have very high rates of cure or long-term remission. Now, some diseases we're not doing as well, such as AML, stage 4 neuroblastoma, and infant brain tumors. And actually, those numbers are much less than 50%. Now, this slide's a bit out of date, but I think the trends, if you look at sort of from the 60s, 70s, all the way up, it gives you an idea of the percent survival. And certainly we have some that do very, very well, albeit not without morbidity. Leukemia has sort of been the poster child for success. And then we have some others that are kind of grumbling along. AML is certainly better than it used to be. So just in my career, we've seen improvements. But some of these are leveling off, and we're really not making much further advances. So the main reason why ALL, as sort of the most common diagnosis, has done well has been cooperative clinical trials. So if you go back to the 60s, when I was just entering into the early years of elementary school, you see why my classmate probably didn't come back. We were just beginning to start to do clinical trials. Some patients were making it. And as you go up sort of each set of studies building upon prior successes, the success rates have improved, and now some of our patients are way up here. So now I'm going to shift gears and go into brain tumors, which is my comfort zone. And this is a brain or pie chart that shows the frequency of childhood brain tumors. And what you might appreciate without knowing anything about brain tumors, you're seeing a lot of words on this slide. There are many different histological subtypes. So to say a child or an adult has a brain tumor can have a different connotation, many different types. Now, I already told you in one of the first slides that the most common malignant brain tumor in childhood is medulloblastoma, but the most common brain tumor in children is the low-grade astrocytoma. So if you have a question on your Royal College exam questions, and I don't write them, make sure you read, and if it says malignant or it says brain tumor without the word malignant, you're going to have a different answer. But you'll notice there are a few others that we often don't think about, especially in adults. This ATRT, atypical teratoid rhabdoid tumor. I'm not going to talk about it any further other than to point out that some of our early bad outcomes in infant medulloblastoma probably included this entity. And now that we're able to tease them apart, our success rates in part are removing the bad actors that really are different diseases. Now, in adults, it's a really different story, where almost all the tumors are infiltrative astrocytomas. In fact, the most common diagnosis is the malignant glioblastoma multiforme, which is very, very uncommon in children, about 7%. So I'm going to just use one disease just to show you how cooperative clinical group trials and genetics have made a tremendous advance in my career. So first I'll tell you that medulloblastoma, although it's a grade 4 tumor, it's malignant, is treatment responsive and is cured at a very high rate. The treatments involve multimodalities, that means surgery, radiation, chemotherapy, and our successes have been due to cooperative group studies. Without cooperative group studies, we would not have made advances. So for those of you who are just interested in what's the punchline, if you have average risk disease, and we define that as children over the age of 3 years with very little residual tumor in M0, which just means no evidence of metastatic disease, the outcomes are pretty good. In fact, we're approaching about 85%. However, those with high-risk disease that have a lot of residual tumor that the surgeon can't remove or evidence of metastatic disease, it's intuitive that the cure rate would be lower. Infants don't do well, but part of the reason is we tend to avoid or delay radiation. And then, of course, regardless of what you come in with, if the disease comes back, we do very, very poorly. So what's happened in average risk medulloblastoma is less is more. It used to be that children received 36 gray to the neuraxis. That means they would get whole brain radiation and radiation to the spinal cord to a dose of 36 gray, and then they would get a boost to the posterior fossa where the tumor is. That's for local control. And basically, we've been lowering the dose to 18 gray. So that in the last 20 years, 50% reduction in craniospinal radiation. And there's talk that there may even be a subgroup where we may even think about omitting craniospinal irradiation. We've also implemented, when I say we, the royal we, the radiation oncologists have used modern imaging techniques and image-guided radiation to do conformal three-dimensional treatment planning, and that can reduce the dose of radiation to the cochlea and reduce morbidity. They maintain the dose to the local area because you want to cure the patient, and we've also continued to use adjuvant chemotherapy. So the goal in average risk medulloblastoma is to reduce long-term sequelae, that includes to endocrine neuropsychological systems, but also maintain good cure rates. So we're trying to reduce the treatment, but we want to maintain the cure rate and minimize toxicity. Now I'm going to show you some what we call Kaplan-Meier survival curves, and I'm going to use these terms, event-free survival and overall survival. Event-free survival means that when does the first event occur? It could be recurrent disease, it could be toxicity, it depends what your outcome is. And then overall survival means what it means. So you would always expect that overall survival to be longer than event-free survival if you have some sort of salvage therapy. If event-free and overall survival overlap, that means that you're doing well, but when your disease recurs, we have nothing to offer. So this is just a pictorial example of conformal radiation. And I'm not a radiation oncologist, but with these image-guiding techniques, you can focus on where the tumor is and avoid critical structures like the cochlea. So this is just an example of a study, and this is how we've made progress. So this takes us back about 15 years ago. And what they tried to do there, they said, well, maybe children should get less radiation in standard risk patients. So they cut the dose from 36 gray to 23 gray, but these patients didn't get chemotherapy at all. And adjuvant means the chemotherapy is given after the radiation. So look what happened. You just take 8 years event-free survival. Those who got 36 gray, no chemotherapy, 2/3 survival, whereas those who had the reduced dose, half survive. Now you could look at this two ways. You could say, well, then maybe we should just go back to giving the high-dose radiation. Or you could say, oh, look, half the kids with less radiation do well. Maybe if we just give them chemotherapy, we might get to better results. So with the reduced dose craniospinal, they certainly had an increased risk of early relapse and lower survivals. So the next study added in the chemotherapy. So they actually went ahead with the study. And look what happened. The event-free survival was about 80%. And that's great. And the most recently completed study from Children's Oncology Group, the event-free and overall survival are pretty good using this reduced dose craniospinal and adjuvant chemotherapy. Now, this study compared two different types of chemotherapy combinations, and there was no difference. So this is the kind of survival curve you want to see for most diseases. So the x-axis is the time since diagnosis or from study entry, and this is years. So you always want to see years on the bottom as opposed to weeks or months. And if you live forever, your survival curve is going to look like this. So as you can imagine, if this is a lifetime thing, everyone eventually is going to hit the bottom line here. But for a 10-year study, this is an excellent outcome. So this is what we're now, in some ways, advertising or marketing to our families. If you have a child with medulloblastoma, standard risk or average risk, good resection, no evidence of metastatic disease, we will give reduced dose craniospinal radiation, we'll give adjuvant chemotherapy, and about 85% will be long-term survivors. What about the high-risk patients, though? Well, we know that if you leave bulky tumor behind, you do worse. This is an old study, but we know that the young patients do worse, but many of those patients are not getting radiation. We know that metastatic disease does worse. These are all rather intuitive. And until literally a few years ago, these were the only prognostic factors we had for medulloblastoma. So I need to define metastatic disease because it's a little different than what you might think about in other. So M0 just means there's no evidence of metastatic disease. If you have a positive CSF study, and this isn't CSF that the surgeon takes at the time of surgery because that can have false positive. It's a lumbar puncture done more than 2 weeks post-op. If you have CSF, it's called M1. And then if it spreads throughout the neuraxis, you're going to see higher numbers. If it spreads to the bone marrow, we call that M4. M5 is what James Bond works for. All right, it's a bad joke, but best I can do this morning. All right, so what does this look like? Well, actually, it can be often fairly subtle, and you really sometimes need to be a neuroradiologist to pick up these little lines here. But sometimes it's not subtle at all. It's these big golf balls. That's nodular enhancement. Not good. So these are studies that are not highlighted, and I always make a point to highlight them because one was done by a Canadian. These are both done at St. Jude. They're not randomized studies, but they bring home a point. One was, someone said back in the day when everyone was doing shunts, and now our neurosurgeons try to avoid them, comparing shunt CSF to lumbar CSF, and they're able to show that the lumbar CSF has a higher rate of detection. And you can certainly have false negatives with the shunt CSF. So you need to do a lumbar CSF. And I still have to tell various clinicians of various specialties that we need a lumbar sample. So this has not trickled down to the people on the street, except in our division, of course, because we're all fantastic. Now, this is another important study saying, well, okay, now we have spine MRI. Why do we need to do an LP? Well, you can have false negatives using either. So if you use both, you're more likely to have a positive, or you're more likely to make the correct staging. And staging is important. So now I'm just going to quickly zip through the other two risk groups. The high-risk patients, well, we really need to intensify therapy because we can't be cutting back. So 36 gray seems to be the way we're going. Now, as it turns out, what some groups are doing they're giving high-dose chemotherapy in what we call tandem transplants. So after the patient gets chemotherapy, their stem cells are harvested and they're kind of banked, their own personal bank. And then they get more and more high-dose chemotherapy, and we infuse their own marrow in, and their marrow is negative. So the marrow is really a form of self-rescue. So this is now being done in places like St. Jude in sick kids, and we're doing it here in selected patients. And the event-free survival is pretty good, 70%. It's not great, but pretty good when you think about the high-risk disease. And there's an open study right now that we're randomizing some patients to, where we're giving carboplatin to improve radiation, and then we're giving, isoretinoin or Accutane after treatment as a differentiation agent. Now, the baby's big problem still. And what we're beginning to think about in the babies is that maybe we should radiate some children sometimes, and I'm not sure why it keeps on going back. And maybe that it will be safe to provide involved field radiation but not craniospinal. And we're also thinking about ways to go back and have the surgeons do what we call second look surgery and take more out. However, most of the infants in North America are getting high-dose chemotherapy with autologous stem cell rescue that I mentioned. Now, there's a very interesting study that was published in the New England Journal. I'm trying to keep this sort of as a data-poor talk just to cover concepts, but this was really important. This was a German study, and they had really, really good outcomes, not 20%, but almost 70% outcomes for infants with M0 disease, so no evidence of metastatic. Now, this was a small study with only about 43 patients. And what they did, which was really important in the studies, they did a lot of neurocognitive testing as well. And they also used a lot of methotrexate. So here's sort of their outcome. No residual tumor, great outcome if you had metastatic disease, so nothing new there. Metastatic disease still played out a role. But something else came out of this study, that not all medulloblastomas are the same. They may all be called medulloblastoma. They are all grade 4 or malignant, according to the World Health Organization, but some histologies do better than others. And this was considered a bit controversial because not everyone's been able to reproduce these studies. But classic Coke doesn't do as well as Coke Zero or desmoplastic, and I'll show you a picture in a moment. Now, recurrent disease, really bad, and we're really pushing patients to go on to clinical trials. But certainly, high-dose chemotherapy and stem cell rescue seems to become the standard of care in patients who may be well enough to receive it. But outcomes are still quite poor. So I'm just going to show you some pictures of the histology, just to give you an idea that not all that's called medulloblastoma looks the same. So this is classic medulloblastoma, but it looks like every small round blue cell tumor that we see, not much to really distinguish it. This is the desmoplastic, and you can see these sort of nodules, and here's sort of the small tumor cells streaming by. And these patients tend to do better in all age groups. And then there's another group called the anaplastic or large cell, and these cells, as you can see, are much larger, and many of them express an oncogene known as c-MYC that correlates with poor prognosis. So what's new in medulloblastoma? In some ways, we've really pushed the envelope for our clinical treatment, and we're making some refinements, but we're really not going to get better survivals than what we have. So how are we going to really approach cure rates of 85, 90% for all patients with medulloblastoma? And the answer is molecular biology. And this is a general pediatric talk, so I'm just going to talk about principles. And this has all happened in the last 10 years, and the kinds of experiments I'm showing can be done in almost any lab here at the University of Alberta in an afternoon. So it's very simple. If you have a sample, you can compare tumor to normal, or you can take normal cells from a patient compared to their own tumor cells, and you label one with a red dye and one with a green dye. One will go in one direction, so molecular 5', 3', one can go in the other direction, 3', 5', and then you can hybridize them, and then you can look for things that are the same, where the red and the green will hybridize together, or more green or more red, and see what happens. So it's a bit of a fishing expedition, but with today's technology, you can get an answer on every gene in the genome, literally in an afternoon. So Scott Pomeroy, who's a pediatric neurologist at Harvard, did this sort of experiment, and he was able to show, you can't read this, but there are different types of brain tumors here. He's able to distinguish medulloblastoma from peanuts. So these are called heat maps, and if a gene's underexpressed, it will be red, and if it's overexpressed, it will be blue. And these are all the different genes. So you're not expected to read this, you're just trying to look at how this is put together. And the scientists don't even assemble this. They have computer programs that use an unbiased approach just to put like with like. So you can learn a lot of information without even drilling down into the details. So what else it can do? It can distinguish classic medulloblastoma from desmoplastic. And these are all the different genes. It can distinguish survivors from people with treatment failures. It can distinguish metastatic disease from non-metastatic disease. And then you can start looking down at the genes and see if any of this makes some sense. So about 8 years ago, a couple of groups published 2 papers in the Journal of Clinical Oncology to see if we could add in this sort of gene expression profiling to the things that we already knew about age, extended resection, metastatic disease, and see if anything would come out. And these studies are small, but the gene expression profile was as good a predictor as metastatic disease in this study. And in fact, if you put them together, sorry about that, here's the low-risk gene expression pattern, no evidence of metastatic disease. That's a great survival curve. But those with a high-risk gene pattern and metastatic disease, really poor. So, just to sum up medulloblastoma, principles of therapy. We want maximal safe resection to reduce tumor burden. We've reduced the dose of craniospinal in our average-risk patients to reduce treatment-related toxicities. The radiation oncologists are using conformal radiotherapy 3D treatment planning, and we're using adjuvant multi-agent chemotherapy. So now I'm going to wake you guys up, and we're going to do another interactive question. Why do teenagers with cancer fare poorly when compared with younger children? They may present late with advanced disease. Treatment-related toxicity leads to reduction or discontinuation of therapy. Decrease accrual to clinical trials. Access to tertiary pediatric care, or all of the above. I think the answer is obvious, but let me start. Okay. You may have to click again because. Okay, I'm going to stop and display because you're right. All of the above. So teenagers are a big problem for us in pediatric hematology oncology. So they often present late with advanced signs and symptoms. A case that comes to mind, we had, when I was practicing in Winnipeg, we had a 14-year-old boy came in with a testicular rhabdomyosarcoma stage 4. He wasn't telling his mom that there was something going on. He waited a long time. We actually salvaged him, but it was not easy. There's the famous line that these kids fall between the cracks between the pediatrician, the GP, family doctor, and the adult healthcare system. And unfortunately, this is very true. They also don't tolerate the therapy as well. For us, middle age is a 12-year-old and above. They do not do as well with treatment. It's often hard to get teenagers into clinical trials in young adults. And then some might argue that there are differences between pediatric and medical oncologists. Now, this is possibly an unfair statement. I think it's the team that we bring in pediatrics compared to the team in medical oncology. I think the doctors are both very good. But we have a team, and one might argue we take the time to look at all the details. So this is an old slide provided again by Paul, but it just shows that as you go through the various age groups, we have this valley between 15 and 30 where patients are really not being entered on clinical trials. And one would argue that with decreased accrual in clinical trials, we have decreased survival, we have worse outcomes. So back to what I know, medulloblastoma, we belong, as well as all the 17 other Canadian medical schools, to the Canadian Pediatric Brain Tumor Consortium. It's a volunteer group, and we pulled our data on medulloblastoma. In this case, we were looking at the second decade of life. Those are 10 to 19. So not too many patients, lots of different treatments, and about half were standard risk. And actually, overall survival and progression-free survival were good. But let's look at the journey of the patient through this treatment. Hearing loss, neurotoxicity, hematotoxicity, which doesn't bother us too much in peds-hemonc. But weight loss, more than 10% of body weight, 3/4 of patients. Having to put in G-tubes, almost half the patients. Dose reductions, and 25% reducing or going off protocol. This is very reminiscent of the adult experience. Furthermore, what about patterns of relapse? Not early, but late. And in adults, medulloblastoma, you can have late relapses I've seen as late as 18 years after diagnosis. And the time to relapse increases with age. And then, as I told you already, when you relapse, it doesn't matter where you are, you don't tend to do very well. So within risk groups, we're beginning to think that not only do we need to change the game, but maybe we need to personalize therapy. And I only have a couple of minutes just to go over this concept. But the idea is here. If we have any kind of cancer, and we treat, in this case, this is from my colleague Stephen Yip, he's a neuropathologist at the BC Cancer Agency, and you've got 100 patients with glioma, and we give them a targeted therapy because we've found a gene that's really important, and we want to target that. You may only help 1 out of 10 patients. However, if you then separate these patients, and remember, under the microscope, the tumor looks exactly the same, but they all have different mutations, and then you give each a specific therapy, you might get better signal-to-noise ratio. There are many clinical trials that have been done in children and adults where we've used targeted therapies, but it's not done by selecting patients. The drug may have some activity, and the company says, sorry, we're not going to study this any further. So we're now in this era that we're beginning to do this quite a bit, and also not just in adults, but in children. And the reason for that is a large collaborative efforts to look at rare tumors. So Michael Taylor, who's a pediatric neurosurgeon in sick kids, managed through his force of personality, and if those of you know him, or just nudging until he got what he wanted, to get 1,400 medulloblastoma samples from across the world. And they started to do gene expression studies and everything else. And using the unsupervised clustering of the computer, they came up with 4 different groups, 2 that are named after signaling pathways that I don't have time to talk to you about, Wnt or wingless, sonic hedgehog, which sounds like a video game, Group C and Group D, which are not very interesting names. But you can see here that and what they did is they're including not just the molecular subgroup, but age histology for those of you who are near the front. And this is what another way of mapping the data. You can see that patients with the Wnt's really separate themselves from the sonic hedgehog type of gene expression pattern, and the Group C and Group D overlap. But they went further. They tried to track this, and you can see here, for example, that the sonic hedgehog group, we see this in infants, but we also see this in adolescents and young adults. And whereas the Wnt one is the low level, and that seems to correlate more with what we see grumbling throughout childhood. And then they went in further and looked at the distribution of these groups. So we're beginning to see that there are some differences and similarities between different age groups, which could also contribute to outcome. But what's really important with this, because all of this stuff, and even though I do this in my lab, it's really how do you make it accessible to the community? How do you translate this? So this study was published in about 2010. They identified 4 antibodies that could actually identify whether a tumor is a Wnt tumor, a sonic hedgehog tumor, a Group C or Group D. And these are antibodies that our pathologists can then use in the community. So it's 2 years to translate this data. And what else they were able to do now using the antibodies, not fancy gene expression, they get the same distribution of the cases. So we're going from gene discovery to something in the clinical lab in 2 years. So what's happening with this is now you can look at these subgroups and outcomes, and you get this sort of picture. So look at the Wnt pathway. This is a survival curve, and this is 15 years. That is awesome. That's not similar to any of the curves I've shown you before. And then you look at Group C, that looks pretty bad. We've seen lots of those. So perhaps there are groups of patients, even though I've told you all the average risks do pretty well, 85%, maybe there's a group of patients with Wnt pathway problems that should get less radiation, or maybe just involved field, or maybe none at all. So the field is moving in rapid ways, and clearly with this group, we've got to really rethink the whole treatment paradigm. So future studies are going to stratify individual patients on the basis of not just clinical, but molecular markers and assign treatments on that basis. We're also going to be looking at specific growth factor signaling pathways. And the ultimate goal, regardless of the details, we want to maximize long-term survival, minimize toxicities, and optimize neurodevelopmental outcomes. Because after all, we're pediatricians, and that's why we think we do a better job than our adult colleagues, because we focus on trying to give these children a better life as well. It's not just survival at all costs. So this is the last interactive question, and it's a pretty easy one, but we'll do it. Now that the majority of children with cancer are cured, 70%, why do they require careful follow-up? To monitor early and late toxicity, because there are relapses off therapy, because of adjustment to school and community, second cancers, or all of the above. The answer is obvious, so I'm going to stop. Yes, all right. You guys are awesome. All right. So I'm going to just, now we're into the last few minutes of the talk. So everyone worries about late effects, but remember, if you don't cure the patient, you're not going to get to late effects. We have some families, they are absolutely paralyzed. They don't want to go on a study. It's not because, and it's often ALL patients, we're comparing 90% survival to 91% survival. But they read the consent form, they get really stuck on the details about effects. Yet, we often have to remind them that none of the treatment we're offering, the drugs are all known. We've been using them for 30, 40 years. There's nothing experimental. The question is, are they going to get one drug IV or orally? Or are they going to get a lower dose or a higher dose? These are really fine detail questions. But they focus on the effects. And clearly, most of the survivors we see out in the community, they feel normal. But many of them have serious sequelae of the treatment. So here, going back again, what do I know? This is my favorite tumor, one of them, medulloblastoma. And our surgeons, we have excellent pediatric neurosurgeons here, will take this out, and we'll get an 85 to 90% cure rate. So, and here's the CT scan showing an excellent resection. So what goes wrong? And many of us have seen this, cerebellar mutism. Up to 25% of patients who've had just a posterior fossa operation will have the serious sequelae, and this could affect their speech, behavior, and although many of them improve, many of them don't quite get to baseline. And we recently had a child on the ward with this. It's really quite remarkable. Surgeons have tried different approaches. Instead of splitting the vermis, they're trying a teloviral approach. But the bottom line is we're not entirely sure what causes this and what to do about it. Neuropsychological effects of our therapy are significant. Now, the cerebellum itself plays a role, but we really need to do a better job both getting baseline studies and getting post-op neuropsychological testing. It's one of my favorite stump speeches. We need more. And the sequelae are due to lots of reasons, and I didn't even list the most common one is the actual tumor itself, which seems obvious, but and we like to blame our radiation oncology colleagues, but intrathecal chemotherapy can have an effect. High-dose therapy, we've all heard of adult patients to talk about chemotherapy fog. It's not a joke, it's a real thing. And then, of course, the tumor itself and the surgery. Many childhood leukemia survivors have neuropsychological sequelae. Many of them are irreversible, but there are interventions and approaches that we can use to help these kids get into the community. And this is a very stark reminder. Now, this is based upon data from 10 years ago, but that IQ, so treatment ends, IQ continues to fall in many patient groups after craniospinal irradiation. So this is, and when you get IQs below 70, we're not necessarily having people achieve their potential, and it's not static after treatment ends. So going back to that infant German medulloblastoma study, it was quite interesting. Here's the control group, and their IQs are all around 100 here. Look what happens, oops, if they just get systemic chemotherapy, they don't get intraventricular chemotherapy, they're not getting radiation. Their IQ is still pretty good overall. As soon as you add an intraventricular, it drops. You add radiotherapy, it drops even more. Radiotherapy intraventricular. So the more we do to get survival, the worse it is. So we really need neuropsychologists, and they liaise with the school system. Now, I can't just talk about the brain. I have to talk about a few other toxicities just to round out the talk. So the anthracyclines are a problem, and there may be a threshold dose-related. But as we go forward now, and there are people like Lipschitz, who works in Florida, are wondering maybe perhaps this threshold is a bit of a misnomer, and that there are patients at risk. So they're now looking at single nucleotide polymorphisms. Are there some children at genetic risk for more disease? And then what are the best markers? So currently, right now, we're limited to echocardiograms and some cardiac biomarkers, but there's a lot more to do. And many of our clinical trials are starting to use cardioprotectants, although we have to be sure that these weren't mitigating the effects of chemotherapy themselves. Second, cancers. Everyone worries about that, and my usual answer when I'm talking to families is, don't worry about the cancer your child doesn't have, let's worry about the cancer your child does have. But we're having, over the years, better ideas. Some children are actually a genetic predisposition to get a second cancer, and many of them may have, for example, the Li-Fraumeni syndrome. We know that some chemotherapy is more carcinogenic than others, such as etoposide, radiation, of course. But it's very complicated, so people have made their careers in this area. Of course, any other organ is fair game for our poisons, and I don't need to remind you of that. But clearly, we need to follow these patients for long term to pick these things up. And it's really hard to expect the family doctor in the community to be able to juggle this and keep up with the latest antihypertensive and everything else. So it's really becoming an area for the experts. One of the best published people who looks at late effects is a family doctor who works at Sloan Kettering Memorial in the children's oncology. So he's taken the community approach but brought it into the cancer clinic. So this is my last slide. Overall, our goal is to cure and heal the child and the family. It's complicated, but we really need to look at ways to not only improve our therapies, but look at the outcomes and follow the children. So with that, I'll just remind you what I just told you about. I've given you an overview of childhood cancer with my own personal bias on brain tumors. I've shown you the example of clinical trials, briefly through leukemias and also medulloblastoma, to show that by entering children on clinical trials, we've made progress in my lifetime. I've told you a little bit about how we're incorporating cancer genetics to subclassify tumors that all look the same under the microscope and come up with perhaps new approaches, in some cases lessening therapy. I've explained why we need to follow up cancer survivors, and Maria Spavor in our group follows patients. Her oldest survivor that she's seeing in the clinic apparently is 65, so that's really something. And then I've briefly mentioned adolescent and young adults, and our center and others are now making a concerted effort to integrate our therapies with our adult colleagues. And I hope in the near future we'll have physicians based at the Stollery and the Cross at the same time who cross both sides of the road. So now I just want to finish up. This is my very last slide. I want to thank Dr. Grundy for letting me use some of his lectures slides, because then I didn't have to recreate them from scratch. And I want to thank my own supporters of my lab, the whole family, the Kids with Cancer Society, and the University of Alberta. And I'll take any questions. Thank you very much. Oh, so are there any questions from sites so far? I know one is Royal Alex.
While they're thinking, if there are any questions here? Scott.
In all these studies, what is the definition of cure? Do they say 5-year survival rate or 10 years?
Okay, well, I'd say the definition of cure is a bit of a moving target. In fact, families are really, really mystified by that term, and we often have to spend hours just explaining. So the first word that is a conundrum for most is, what is remission? So you may see in your reading CR, complete remission, or clinical remission, depending on how you define it. And in the old days, for leukemia, if the pathologist looks at the bone marrow 7 days after treatment, sees less than 5% blasts, that patient's in remission. We've subsequently learned that that may not be the case, and there's now a concept called minimal residual disease. So our definition of remission is now changing. People might say 3 years out, if there's no evidence of disease, you're cured. But I know that there's some subgroups of medulloblastoma that can occur 5, 10, 20 years later. So is the patient cured, or are they in long-term remission? So families really like the word cure, but it doesn't mean you're off scot-free. So I know I'm not giving you a good answer. I almost sound like a politician. But cure is a hard word. However, I'd like to challenge or throw the gauntlet to all the other subspecialists in the room. We actually use the word cure in oncology, and a lot of diseases that are chronic, you're not curing, you're controlling. So I think we can say that we do cure children in pediatric oncology. So how's that? There's the challenge. All right. Good morning. Hi, Rena. Go ahead.
Thank you for a very informative round, David. You've clearly kind of expressed how complex this rare group of childhood conditions is and what advances over the last 3 decades have occurred in treatment modalities and in prognosis. You're also very well aware that of my interest in pediatric environmental health and the research that we're engaged in children's cancer and industrial pollution. I guess what I'm kind of mulling over here is you've mentioned that there is less of an environmental contribution to children's cancer, and yet I think that statement would need to be qualified, that perhaps we haven't identified the role of any environmental contribution as yet in children's cancer. So, bearing in mind my interest and the team's interest, the research team led by Alfredo Antonio, I guess my question is, in the grand scheme of things, what is the next research contribution that you see to helping children's cancer? I know it's a very difficult question, but research is moving forward probably faster, a lot faster at the treatment end than at the prevention end. But with these group of conditions being so complex and the implications being so huge, where do you feel that our biggest bang for the buck is in the next 10 years?
Okay, I'll attempt to answer that question. And I knew that, well, Alvaro was in the audience, and I knew you might be lurking out there. So I made that comment fully expecting to get my comeuppance. People have looked for the last 40 years for what is the cause of, let's just go back to childhood leukemia. And we certainly know if you were near Chernobyl when that happened, and you're within a certain radius, you're going to get leukemia at high rates or other lymphoproliferative disorders, and that's well documented. And the further away you are from the blast, the less likelihood. So there's a link to exposure to radiation in childhood leukemia. So we know the environment is important. But people have tried to look at exposure to high electrical fields and everything. There was a study, a very innovative one, where they had school children in various areas in North America wearing backpacks to pick up dosimetry from radiation and power outlets and what have you, and they couldn't really find a close correlation. So it's been very hard in population-based studies to find the cause of childhood leukemia, which is our most common diagnosis. That being said, there have been clusters of cases in California near mines where they have, for example, tungsten has been linked in a few clusters. The problem is that these clusters are so small, and it's very hard mechanistically to prove this in the lab, let alone develop animal models. So I think we're a long way off. I think with the more or less mastering the genome, that in the next few years, we're going to get a readout on everyone, like a barcode of the patient's genetics. So to me, the next big change or challenge is going to be a field of epigenetics, which is non-heritable changes to gene expression. And that's where I think we're going to find better links between the environment and gene expression. But that's going to take not just my lifetime, but the lifetime of the trainees in the room to really tease that out. It's a big, big challenge. But I think we'll have better ideas. And certainly, during childhood, any sort of exposures that we know are related to any disease should be avoided because we're really setting them up for something later on in life. My comment was simply that we're not really seeing the impact of environmental exposures in the childhood years, but we do see it later.
In the interest of time, we have 5 more minutes. That's a little bit fast. So we can take 2 short questions or 1 long question. So pick your choice. Bob.
I think we have now 2 childhood tumors that can be tumors that can be cured with vaccines, HPV and parvovirus. Do you foresee more vaccines available for childhood cancer?
Okay, so I'll just repeat what Dr. Moriarty said. he stated that there are 2 cancers now that we can prevent, hepatocellular carcinoma from hepatitis B, although we're not vaccinating to hepatitis, well, we have liver people in the room. There's a whole alphabet soup of hepatitis, and I'm sure there'll be others to come up, but that's been a major problem worldwide with cancer, both in children and adults. And then, of course, cervical cancer and other cancers related to the human papillomavirus. So that's been an amazing thing, and I need to incorporate that in the next version of my talk. There are some other vaccines in the works, but they are rather specific right now. So if I were giving this talk to an adult brain tumor audience, about 40% of adult brain tumors, malignant gliomas, have a mutation of the epidermal growth factor receptor. And there are now vaccines, and the trial opened at the Cross Cancer Institute to vaccinate patients that have that type of mutation in their tumor, and to lead to a better tumor response, a long-term remission, although it's not going to lead to cure because their cancers are much more complicated than that mutation. But whether or not we're going to be able to vaccinate for others would really depend on knowing what the cause is, and to date we don't really have a viral link. You would think that childhood leukemia would be the perfect cancer where we find one virus, but that's really not the case at all. And just because I have somewhat of a captive audience, I'm just going to mention a really interesting study that kind of got buried, but I thought was fascinating. Dr. Mel Grieve from England thought it'd be really cool if you could look at umbilical cord blood and send it off to the flow cytometer. And what he found was that a large number of infants have leukemic clones in their cord blood. Yet, almost none of them developed leukemia. So clearly, the children's own immune system and surveillance is getting rid of some of these clones, only very few. So it's possible that a lot of kids in the community have leukemic clones, and then it's just some sort of viral exposure, may not be specific, some environmental exposure, again, not specific, that tips them over. But no one's been able to really prove that. At present, it's just a hypothesis.
I think with that, we'll bring it to a close. Thank you very much, David, for an excellent talk.